So,
good afternoon. My name is Chris Colby. I'm a professor of pediatrics. I'm also the division chair for Neonatal Medicine here at Mayo Clinic. It is a real honor to be able to join your conference remotely today, and I appreciate the organizers' invitation to present. Unfortunately, because of COVID-related travel restrictions, I have to do the presentation remotely. In January of 2020, I had the great opportunity to visit your beautiful city of Dubai and present at the Arab Health Conference, where I was able to see your wonderful city and meet your great people. I look forward to the day when we can travel again. So we have two different objectives in the next half hour. In section 1, there'll be an overview of premature brain injury. And then in section 2, we will examine what strategies are effective in the prevention of neonatal brain injury. As far as introduction goes, hypoxic ischemic brain injury of a newborn results from hemodynamic alterations. These can occur in the perinatal period, in the interpartum or the birthing process, or in the immediate newborn period. Hypoxic ischemic brain injury adversely affects selectively vulnerable areas of the immature brain. There are distinct gestational age dependent differences in the vulnerability of specific cerebral structures. The most vulnerable areas are those that involve cerebrovascular immaturity and biochemical immaturity. The nature of the injury and the long-term sequelae is determined by the specific site of the brain injury or damage, by the severity of the injury, by the duration of the hypoxia and ischemia, and when exactly the hypoxic ischemic insults occurred. Perinatal asphyxia occurs more frequently with decreasing gestational age and birth weight. So the younger and less mature the baby, the higher the risk. And its incidence at 28 weeks is 30% compared to only 2 to 3% at term. There are some characteristic neuropathologic lesions in areas of the premature brain that are especially susceptible to hypoxic ischemic damage include the basal ganglion, the brainstem, the cerebellum, and the spinal cord. Of greatest developmental consequence to the premature baby is the vulnerability in the periventricular regions to hypoxic ischemic injury, as evidenced by the development of periventricular leukomalacia. Periventricular leukomalacia, abbreviated PVL, in the periventricular regions of the premature brains, vascular anastomoses are not fully developed, so there is an increased susceptibility to a reduction in cerebral perfusion. Resistance of the periventricular regions to hypoxic ischemic injury improves after 35 weeks gestation, leaving the premature babies uniquely vulnerable to this injury. Cellular susceptibility also lessens with brain maturity. The most common neuropathologic lesions associated with hypoxic and ischemia in premature infants is periventricular leukomalacia. Severe PVL in premature infants leads to cystic degeneration and atrophy of the periventricular white matter. And there is a high correlation that exists between the extent and type of PVL and the severity of the final neurological impairments. Premature infants suffer fewer major handicaps from even the most severe asphyxial insult. This is evidence that immature nervous systems have a greater resistance to hypoxic and ischemic injury than more mature babies. PVL is the most common cause of motor impairment in the premature infants. The periventricular regions are crossed by the corticospinal tracts, which contain descending myelinated fibers, serving as the main output pathways for the motor cortex. Fibers within the corticospinal tracts interconnect with the basal ganglion, brainstem, and cerebellum, with all areas contributing to normal, purposeful motor movement. And here's just an example of the part of the brain most susceptible to this type of injury, just adjacent to the lateral ventricles within the cerebral cortex. And as a reminder, this is the exact area through which the corticospinal tracts pass. Motor fibers to the lower body and lower extremities are located medial within the corticospinal tracts, placing them intimately within the periventricular regions and at risk for PVL. Even mild degrees of hypoxic injury to the periventricular regions will affect the medial motor fibers within the corresponding corticospinal tracts, resulting in functional gross and fine motor problems involving the lower extremities. When this occurs, the injury that you could predict would be spastic diplegia. More extensive insults to the periventricular region affect motor fibers placed more laterally within the corticospinal tracts and controlling the upper body and upper extremities. Such insults result in spastic quadriplegia and cerebral palsy. As an injury moves even more laterally within the corticospinal tracts, motor fibers affecting eye and facial movements and swallowing also become involved. And this is just kind of a graphical representation of the corticospinal tracts that are involved as you move medially next to the lateral ventricle out more laterally. How we move from involvement of just the feet and the trunk to then begin to involve the hands, upper extremities, use of the fingers, face, lips, and tongue, and all the associated activities. The basal ganglia, the spasticity of hypertonicity that frequently occurs with cerebral palsy in the premature infant results from concomitant hypoxic ischemic injury to the basal ganglia. One major function of the basal ganglia is to inhibit muscle tone throughout the body by transmitting inhibitory signals to both the motor cortex and to the brain stem. Basal ganglia are also responsible for initiating intentional gross motor activities, which in turn are fine-tuned by the cerebral cortex. If the hypoxic ischemic injury primarily involves the basal ganglion and spares the cerebral cortex, choreiform, athetoid, or ballistic movements will be the predominant abnormalities seen over time. The onset of these unintentional, uncontrollable, purposeless movements generally is not clinically apparent until after 1 year of age. This makes the prognostication for neonatologists challenging because the baby, while under our care in the NICU, may not be exhibiting any of these motor signs, but these become more apparent with age. Hypoxic injury to the cerebellum is less common in asphyxiated premature infants. It causes diminished capacity for smooth, cooperative, sequential action between muscle groups. Clinical manifestations may not become evident until the child is older and exhibits more complicated motor movements. Motor disabilities associated with cerebellar damage: number one, a complex motor movement appearing as a sequence of irregular, disjointed movements, also known as cogwheeling; a staggering ataxic gait with a tendency to fall; an intention tremor which intensifies as the movement nears completion; and then finally a loss of control of the range of movement, resulting in undershoot or overshoot of the final target. Visual impairments are also associated with PVL. Many premature infants with PVL manifest visual impairments from the hypoxic ischemic damage to the optic radiations. Cystic PVL may result in cerebral visual impairment involving severe loss of visual acuity, a reduced visual field size, abnormal ocular movements, or in the worst case scenario, blindness. Hearing impairment. In premature infants, there's an increased incidence of sensory neuronal hearing loss, which can occur in 5 to 10% of premature babies. Hypoxic ischemic injury increases the incidence to as high as 20%, and of the 20% with sensory neuronal hearing loss, 75% may have moderate to severe hearing loss, and 25% may have profound hearing loss. Cognitive and learning disabilities may also be common. Beginning in the late second trimester, precursor cells in the periventricular regions differentiate into mature neurons that migrate to successive cortical layers. And following migration, the neurons undergo orientation with elaboration of dendritic and axonal connections, creating an intricate system of synaptic connections for the newly formed cortex to other brain structures. The exact cause of cognitive deficits in the asphyxiated infant remain to be clearly determined. In premature infants, PVL plays a major role by interfering with the differentiation, migration, and orientation of the precursor cells, resulting in an abnormal cortical cellular matrix. The degree of mental retardation in premature infants correlates closely with the severity of motor impairments. In other words, the worse the motor impairments, you can predict the worse the degree of mental retardation. Moderate to severe mental retardation is seen in 35% of premature infants with spastic diplegia. In a baby who has spastic quadriplegia, but 75% of that population will have moderate to severe mental retardation. Skills that may be a challenge to an infant with hypoxic brain injury. These could include sensory motor, visual motor, auditory and language processing, short-term memory issues, and the challenges with learning new skills. So now that we've defined the injury that we're trying to prevent, what does the evidence suggest as far as neuroprotective strategies that are actually effective? First, the obvious. If you want to avoid brain injury in the premature infant, do everything you can to prevent preterm deliveries. That kind of goes without saying. Do mothers have good access to healthcare, high quality healthcare? Have we done everything to optimize maternal health and well-being? Do we have advanced healthcare systems, again, without any issues with access, and these are widely available? One of the things that has really been focused on in the United States over the last year is the avoidance of early inductions of labor and cesarean deliveries. It's very uncommon in the United States for a mother to be able to convince an obstetrician to deliver their baby before the actual due date. And this is fairly common practice, even as many as 10 years ago. There's a lot that has been learned about how the late preterm and even early term baby is different than the actual term baby, with morbidity associated with the earlier gestational age. And finally, if we're unable to prevent preterm deliveries, we need to make sure that there are neonatal resuscitation teams that can deliver excellence in helping that baby transition from intrauterine life to extrauterine life with a full host of skills that would be needed to help with that transition. Treatment strategies that have been shown to be effective as far as neuroprotection in the premature, antenatal steroids is probably on the top of the list. There was an excellent Cochrane review in 2017 that looked at this particular question. And what was found was that antenatal steroids, specifically either dexamethasone or betamethasone, reduced perinatal death, neonatal death, defined as death within the first 28 days of age, reduction of interventricular hemorrhage, and were associated with decreased developmental delay. There is weak evidence to support this finding, in part because most of the studies that looked at the delivery of antenatal steroids did not include long-term outcomes for the babies. How do antenatal steroids perhaps improve neurodevelopmental outcomes, promote lung maturation, stabilize respiratory and hemodynamics? They help mature the germinal matrix vasculature and exert a vasoconstrictive effects on fetal cerebral blood flow. And there's protection again against interventricular hemorrhage and hypercapnia-induced cerebral vasodilation that can be a key contributor to interventricular hemorrhage. Another intervention that has been well studied is magnesium sulfate. How would this possibly work? During the acute cerebral ischemia, there's a large amount of excitotoxic amino acids, specifically predominantly glutamate, that's released. This activates the NMDA receptors that operate calcium channels, and there's a large amount of calcium that flows into the cells. Increased intracellular calcium leads to cellular damage by activating proteases, lipases, and endonucleases. What magnesium sulfate does is it gates the NMDA channel and protects the brain from NMDA receptor-mediated injury. We also know that it suppresses seizures, and that in part is why moms with preeclampsia are given magnesium sulfate. It is a bit of a vasodilator, and it decreases the release of nitric oxide and the production of oxygen-free radicals. This was initially recognized in 1995 in an article that was published in Pediatrics titled, "Can Magnesium Sulfate Reduce the Risk of Cerebral Palsy in Very Low Birth Weight Infants?" Apologize for the typo there. And this is an observational study. In the conclusion of this observational study, in utero exposure to magnesium sulfate was more frequent in controls than in children with CP, suggesting a protective effect of magnesium sulfate against cerebral palsy in these very low birth weight infants. So over the course of the next 15 years, multiple different studies were done, included 5 high-quality prospective randomized studies. There's a Cochrane review that was published in 2009 that evaluated outcomes in more than 6,000 patients, and they compared premature babies that were delivered after having received magnesium, their mothers had received magnesium, versus control. And what was shown was for the outcome of cerebral palsy, there's a relative risk reduction to 0.68 that was statistically significant, and a reduction in gross motor skill dysfunction with a relative risk of 0.61, and again, statistically significant with a p-value of 0.003. There is no significant difference in infant mortality. Another intervention that has been shown to be promising as it relates to neuroprotection is that of delayed cord clamping. When I did my training as a resident and a fellow in the late 90s and early 2000s, no one had begun to think about this, but this has really become standard of care again in the United States in the last 10 years. The American College of OB/GYN recommends delayed cord clamping among all preterm infants, and points that there is neuroprotection by delayed cord clamping of the umbilical cord, with a statistically significant reduction in interventricular hemorrhage. No difference. Actually, there was even a difference in sepsis that was seen that was difficult to explain. So the thing about these studies that led up to the conclusion that it was good to do delayed cord clamping in the premature infants is, what about premature babies who are not breathing upon delivery? What's the best thing to do there? Is it to deliver the baby and immediately cut the cord, clamp the cord, or is it better to deliver the baby and begin resuscitation while you wait the 60 or 90 seconds for delayed cord clamping to occur? So what we know is delayed is better than immediate early cord clamping for preterm infants if the babies are breathing. There have been 14 randomized controlled trials of preterm infants comparing delayed cord clamping versus immediate cord clamping, more than 600 preterm infants, immediate versus delayed. No difference in mortality, somewhat surprisingly, but what has been shown is less need for vasopressors and packed red blood cell transfusions, and less interventricular hemorrhage and necrotizing enterocolitis with delayed clamping. But non-breathing infants were generally excluded from these studies. So if the baby didn't look good, the default was to clamp the cord, cut the cord, and then begin your resuscitation. There have been preclinical animal trials that have looked at this concept that have been quite interesting. I'll draw your attention to the first graph on the top that has the red, green, and yellow lines. And what that demonstrates is preterm lambs who are born at the equivalent of 28 weeks gestation. And the way that they were resuscitated was they were delivered, they began to be ventilated, and then the cord was clamped at about 2 minutes of age. And what you can see in the red, green, and yellow line is how stable the cerebral oxygen saturations, peripheral oxygen saturations, and heart rate is maintained when the babies are ventilated first before the cord is clamped. In the second group, or the lower part of the graph, what it shows is the group of lambs who were delivered. The cord was immediately clamped, and then ventilation was delayed and begun at a couple minutes of age. What you can see is a precipitous drop in cerebral saturations, peripheral saturations, and bradycardia until the baby was, or the lamb was begun to be effectively ventilated, which suggested that in babies who aren't breathing, lambs who aren't breathing, it is better to prioritize ventilation versus the clamping of the umbilical cord. This study is actually being done right now in preterm infants, and Mayo Clinic is one of the study sites. And the intervention is our neonatology team provides ventilatory assistance, either CPAP or positive pressure ventilation, during 120 seconds of delayed cord clamping. You can think of the operational and logistical challenges of beginning the resuscitation while the baby is still connected to the umbilical cord, which involves our team being immediately next to the perineum while the baby is still connected to the umbilical cord, and we begin to deliver positive pressure ventilation, or if it's a C-section, being right next to the mom's abdomen while we wait the 120 seconds, begin to resuscitate the baby. Versus the control group of standard 30 to 60 seconds of cord clamping, and then begin your resuscitation. The outcome of the VENT-FIRST trial is going to be reduction in ventricular hemorrhage on head ultrasound at 7 to 10 days of birth, and a secondary outcome reduction in other premature complications. Another treatment that did show promise as far as prevention of perinatal brain injury was Endomethacin, and this was commonly used, at least in our practice, last decade. There was a study that was published that showed a reduction in the incidence of interventricular hemorrhages in preterm infants that was statistically significant. The way Endomethacin might actually be achieving this outcome is by promoting maturation of the cerebral vasculature, blunting of cerebral vascular responses caused by hypoxia, hypercapnia, hypertension, and asphyxia, and Endomethacin improving cerebral vascular autoregulation. However, when a meta-analysis was performed of 19 large randomized controlled trials, found that prophylactic Endomethacin in preterm infants did not improve mortality or long-term developmental outcomes. When that meta-analysis was published, we moved away from using prophylactic Endomethacin within the first 24 hours of age. Erythropoietin is another medication that has been shown to be promising to prevent neonatal or perinatal brain injury. Erythropoietin is known to have anti-apoptotic and anti-inflammatory effects, promotes neurogenesis and plasticity and tissue remodeling, and at least in animal models, promotes migration and differentiation of neuronal precursors. And receptors are expressed in the brain of neuronal progenitors, mature neurons, astrocytes, and microglial cells. There was a Cochrane review that was published that was quite encouraging, that included 4 randomized controlled trials in 1,133 infants. And the conclusion from this meta-analysis, prophylactic EPO improved the cognitive development of very preterm infants, as assessed by the MDI at a corrected age of 18 to 24 months, without affecting other neurodevelopmental outcomes. They suggested that current and future RCTs should investigate optimal dosing and timing of prophylactic EPO and a plan for long-term neurodevelopmental follow-up. This was published in Paediatrics in 2017. And these particular investigators answered that challenge and actually did that study using babies enrolling babies who were born between 24 and 27 and 6/7 weeks, including 741 infants. And they used high-dose EPO in the experimental group, 6 doses, or placebo. The study was published in the New England Journal last year, and their conclusion was high-dose EPO treatment administered to extremely premature infants from 24 hours after birth through 32 weeks of postmenstrual age did not result in a lower risk of severe neurodevelopmental impairment or death at 2 years of age. Moving on to whole body hypothermia for infants. At the time that Dr. Gunn in New Zealand did this study that was published in Paediatrics in 1998, the safety and effectiveness of hypothermia in term infants with encephalopathy was uncertain. And what he did is he had an ischemia reperfusion animal model where they occluded the carotid arteries in the control model and then reperfused thereafter. So in the control group, there was no hypothermia after that injury, but in the experimental group, they either started hypothermia an hour and a half, 5.5 hours, or 8.5 hours after the initial injury. And what was measured was parasagittal neuronal loss, and compared that to control. And what you can see in the animals that had hypothermia started an hour and a half after the initial injury, there was a significant reduction in comparison to controls of parasagittal neuronal loss. Same was true, but to a less extent in the animals who were cooled at 5.5 hours. And that effect was essentially washed out if the hypothermia was delayed until 8.5 hours after birth, suggesting that not only is this an effective intervention, but the earlier it was started, the better. The landmark study that was published to support total body hypothermia for term babies with hypoxic ischemic encephalopathy in the term population was published in the New England Journal of Medicine in 2005. And they randomized infants of a gestational age of 36 weeks or greater and admitted at less than 6 hours of age in either severe acidosis or perinatal complications and resuscitation at birth who had moderate or severe encephalopathy. And they randomized infants either to usual care or whole body cooling to an esophageal temperature of 33.5 degrees for 72 hours, followed by a slow rewarming. Neurodevelopmental outcome was assessed at 18 to 22 months of age, and the primary outcome was a combined endpoint of death or moderate or severe disability. Eligibility criteria included having a pH of 7 or less and a base deficit of 16 or greater during the first hour after birth, or a pH of 7.01 to 7.15 with a base deficit of 10 to 16, or a blood gas was not available. Additional criteria were required, including an acute perinatal event, or either a 10-minute APGAR score of 5 or less, or assisted ventilation for the first 10 minutes of life. All infants underwent a standardized neurological examination using the Sarnat criteria to identify babies who had moderate to severe encephalopathy. Candidates for the study when encephalopathy or seizures were present. Encephalopathy was defined as the presence of one or more signs in at least 3 of the 6 categories. As far as results go, of the 239 eligible infants, 102 were randomized to the hypothermia group, 106 were randomized to the control group. Adverse events were similar in the 2 groups during the 72 hours of cooling. Death or moderate or severe disability, again, the combined outcome, primary outcome, including 205 infants, 44% in the hypothermia group and 62% in the control group, with a risk ratio of 0.72, achieving statistical significance. There is no statistically significant difference in death. And then as far as major disability or cerebral palsy, again, no statistically significant difference. But again, their conclusion was whole body hypothermia reduces the risk of death or disability in infants with moderate or severe hypoxic ischemic encephalopathy. So a question you might have is, it appears that hypothermia is a promising therapy for term babies. Should we consider it for the premature infants? This is a single center observational retrospective study that tried to answer that exact question. For babies less than 36 weeks gestation with hypoxic ischemic encephalopathy, received whole body hypothermia in a single center between 2007 and April of 2015. And again, the primary outcome was death or moderate to severe neurodevelopmental impairment. They had 30 infants, and these were the results. So the median age was 35 weeks with a range all the way down to 33 weeks. The birth weight was 2,575 grams on average, with a range anywhere between 1,850 and 4,840 grams, and a first postnatal blood gas on average of 6.81, so quite distressed population with a range of 6.58 to 7.14. Complications were frequently seen in this population. Coagulopathy was seen in 50% of the babies, early clinical seizure in 43.3%, arterial hypotension in 40%, persistent metabolic acidosis in 37%, and thrombocytopenia in 20%. Outcomes: 4 infants died before or soon after discharge. 18 surviving infants had follow-up data. 7 of them had moderate to severe neurodevelopmental impairment. Death or moderate to severe neurodevelopmental impairment occurred in 50% of infants with known outcomes. So the conclusion from this single center study: large randomized trials on efficacy and safety are needed in this population, as the incidence of complications in the combined outcome of death and neurodevelopmental impairment is concerning. So a summary of my presentation: evidence-based strategies to optimize neuroprotection in the premature. Number 1, avoid premature delivery if at all possible. Number 2, use antenatal steroids to reduce the risk of an interventricular hemorrhage. Number 3, great evidence to support the administration of magnesium sulfate to the mother threatening to deliver her baby prematurely. Delayed cord clamping for the spontaneously breathing premature infant. And although Endomethacin and erythropoietin have shown some promise, neither have sufficient evidence to support their use now. And then hypothermia to 33.5 degrees for 72 hours for the late preterm infant, defined as 35 weeks and above. I thank you for your time. I thank you for your attention. If you have any questions, please do not hesitate to send me questions. I love to correspond with people all around the world. Feel free to take a picture of my email address and email me anytime.